Hi everyone, welcome back to our journal club. I'm just waiting I'm going to try to tag her just to get things started. Dr. Ramika Dhar. Oops, okay. Hey, okay, there she is.
Hi.
Hi, how's it going?
Good.
Good, welcome back.
Thank you.
Thank you. Dr. Dhar is a geriatric psychiatrist in West Virginia, at the West Virginia,
University.
and teaches, at West
Yeah.
Virginia University, sorry. Um, and apparently, delirium is one of her favorite topics. So I'm excited that she is doing tonight's article. So go ahead. Thank you.
No, thank you, Christina. So today's topic is on delirium. This article is published in Education in Behavioral Neurology and Neuropsychiatry. And the title is Responding to 10 Common Delirium Misconceptions with Best Evidence, an Educational Review for Clinicians. So the purpose of this review, as the authors have described, is that they want to make sure that the gap between the evidence that we have about delirium prevention, management, and actual clinical care, that gap is narrowed, because regardless of whichever healthcare facility we are at, we as psychiatrists are always the knee-jerk response team to be called when somebody is delirious. And delirium somehow is still a mystery to internists. So what they did was they used the Delphi method, which I looked up. I guess you have a panel of experts, and anonymously they send you questionnaires and ask about your opinion, and then they finally come to some conclusion. So they basically, based on that method, they ranked them from the highest to lowest importance, these 10 misconceptions. They did a literature review using the keywords delirium with myth, misconception, but they didn't find much except for like two potentially relevant articles, but they were either focused on just normal aging myths or myths associated with sedation and delirium in ICU. So as we know, that delirium is a serious medical condition. It affects about 25 to 35% of older medicine and surgery patients, and almost 80% of ICU and palliative care patients. It is associated with poor outcomes, including longer length of hospitalization, increased morbidity, and also increased mortality. And then the costs associated with the delirium are huge. It's estimated like 38 to 164 billion among 11.8 million hospitalized older adults. So it's an additional per patient cost, 16,000 to 64,000. More than a third of delirium cases are actually preventable, but 2/3 of delirium may go unrecognized. So hopefully, I think that we should really share this article with all our other colleagues in other specialties, and I think that's what my plan is after this.
It's a good idea.
Yeah. So let's talk about the 10 misconceptions, and then the table 1 on page 2 basically lists the 10 misconceptions juxtaposed with the best evidence. So that's just a screenshot of what they're going to talk about in depth. So what misconception 1? Patient is oriented to person, place, and time, so they are not delirious. And this is, I think, we encounter clinically all the time. Patient is alert and oriented times 3. So delirium, by per definition, does not just require disorientation. It's either an acute onset or a fluctuating course. So of course, based on the time of examining the patient, it's going to change. So the patient could be totally lucid and be confused or disoriented at other point of time. Also, in order to meet criteria for delirium, you should also either have inattention, which I think disorientation is actually is less sensitive than checking for inattention when we are trying to capture delirium. So inattention, and as well as disorganized thought process. So that's why the confusion assessment method was developed. The 3D confusion assessment method is a quick assessment with questions which nurses at bedside can administer. So basically in CAM, if all of you are familiar, it's just, features 1 and 2 with either 3 or 4. And feature 1 and 2 are either these acute onset fluctuating course. Feature 2 is inattention, and 3 is either disorganized thinking, and 4th is altered level of consciousness, which can vary from hypervigilant to comatose. So hence, it's very important that we implement some assessment tools, and confusion assessment method has very high sensitivity, 94 to 100%, and specificity is also very high, 90 to 95%. So their recommendation is, we should minimally assess attention, at least assess attention, orientation, memory, and thought process at least once per nursing shift. Misconception 2. Delirium always resolves. And I think this is also a point of discord between us and others. So delirium duration is highly variable. So you can last for hours, but it can last for several months. Even after you've treated the supposed cause, especially in older, frail adults who don't have a good cognitive reserve and are vulnerable. An increased duration of delirium is associated with increased morbidity and mortality. They have quoted literature where longer delirium duration among older adults in ICU is associated with greater 1-year mortality. Also, post-hip surgery, it results in greater functional decline and 6-month mortality. And then even post-acute patients who remain delirious 6 months, they've been found to have 3 times the 1-year mortality rate compared to those who were not, in whom delirium resolved. So they've also mentioned some important studies. One was the brain ICU study. I think Vanderbilt University critical care medicine has done a lot of work in ICU delirium. So in the brain ICU study, they found delirium duration to be independently associated with global cognitive performance at 3 and 12 months after discharge. And 1/3 of the patients had cognitive scores consistent with MCI, mild cognitive impairment, and 1/4 were consistent with mild dementia. Another study that they mentioned was successful aging after elective surgery. Now, this surgery was all non-cardiac surgery of non-demented older adults. And then an early analysis found that delirium was associated with greater impairment 1 month after surgery and accelerated cognitive decline up to 36 months. So basically, delirium can persist. It doesn't just resolve always. Misconception 3. We should expect frail older patients to get confused at times, especially after receiving pain medication. So it's one of our ageist attitudes in medicine is, older adults should be confused. Why wouldn't they be? But confusion should never be expected as normal part of aging. So clinicians should evaluate for delirium with any new onset confusion or change in personality or behavior. So in fact, the subtle cognitive deficits can be attributed to baseline. And a lot of times on the consults I receive, I get this, that the patient is baseline, like there's nothing acutely going on. Advancing age is actually one of the strongest risk factors for delirium. So basically, we need to be even more vigilant in assessing and preventing and assessing and managing delirium in older adults. American Geriatric Society clinical practice guidelines for postoperative delirium highlights the association between increased pain after non-cardiac surgery and increased delirium risk. The relationship between opioids, pain, and delirium is not clear. Basically, both untreated pain as well as use of opioids are both risk factors for delirium. So But then if you're using pain medications, you shouldn't assume the confusion, attribute the confusion just to the pain medicine, opiate medicines. So basically what we are saying is confusion in frail older adults always requires further assessment. Misconception 4, the goal of a delirium workup is to find the main cause of delirium. And this, I think, is one of the most infuriating things on consults, to be honest with you, is that we have not found any cause. Patient had UTI, it's gone. There's nothing going on. Delirium, by definition, it is multifactorial. And you cannot just find one cause. You may have one inciting factor, but basically it's an interplay of an individual's, predisposing risk factors, their own vulnerability, superimposed with the precipitants, and then you have some perpetuating factors. So for example, an older vulnerable adult, maybe cognitively impaired at baseline, may develop delirium after just a sleeping pill, which is mostly either you have benzodiazepines or they take over-the-counter NyQuil, Benadryl, and that's a very common theme. And then older adults with functional impairment, malnutrition, visual impairment, alcohol misuse, they all carry these vulnerabilities with them. And then polypharmacy, infections, all our deliriums causes that we talk about. I watched death acronym, we all remember from med school. Precipitate delirium, and then the perpetuating factors are just the hospital environment, noisy stimuli, all the mechanical restraints, dark rooms, and dehydration, lack of mobilization. So therefore, although it's important to identify a treatable cause or a modifiable cause, you should still implement multi-component interventions. So in table 2 on page 4, there is a list of online delirium resources. I would like to mention the Hospital Elder Life program, which was started by Dr. Inouye. She actually had published it in NEJM in 1999, and where she talked about implementing this model to prevent delirium in hospitalized older adults. And it basically involved screening for the risk factors and trying to modify them. For example, sleep deprivation, cognitive impairment, any sensory impairment. So it emphasized on a lot of like sleep hygiene, orientation techniques, using hearing aids, glasses, frequently, having a sitter, frequently reorienting them, making sure they're hydrated, making sure they're mobilized as soon as possible. And it was found that as compared to usual care, they could prevent delirium with at least 1/3. So prevention is possible. I guess once you already have the onset of delirium, then it depends based on, the other or modifying factors. So please go look up the hospitalalderlifeprogram.org. It has free resources, handouts, and I use it often to also talk to families about, because they are the ones who get like upset about all these agitation and aggression. Misconception 5. New onset psychotic symptoms in late life likely represent primary mental illness. And as psychiatrists, this is what we are trained in. And not that psychotic symptoms can't happen in late life, but that's extremely rare. And any onset of psychotic symptoms, delusions, hallucinations generally warrants a thorough medical workup or neurological workup. Also need to rule out substance abuse. And in older adults, more often, these psychotic symptoms can also be a prodrome to a neurocognitive disorder. Visual hallucinations are more common. The more vivid they're more common in delirium. But then, audiovisual hallucinations like hypnagogic and hypnopompic, they are just normal variants. It's not pathological. Similarly, new onset delusions, beliefs, they should raise suspicion for delirium. So I guess if we are consulted, I guess part of the liaison is that trying to, teach the team that these symptoms are not, it is not new onset schizophrenia in an 89-year-old. So any new delusions warrant further evaluation for delirium or other medical cause. Misconception 6. Delirium in patients with dementia is less important because these patients are already confused at baseline. And this is also a common occurrence where we just assume, since the patient came in with the diagnosis of dementia, that this is the baseline. Therefore, collateral history is very important to know whether they're coming from home or a nursing facility. That is this a change from baseline? Is this acute or is this different? So even though the delirium incidence is 1 to 2% in general population over age 65, it's present in more than 33% patients with dementia. So every point increase in dementia severity on the global deterioration scale has been associated with 50% increase in delirium risk. Older adults with superimposed delirium also have poorer outcomes after surgery, hip fracture surgery, for example. Similarly, in acute ischemic stroke patients, pre-existing cognitive impairment is associated with a 7-fold risk of developing delirium. And also, subsyndromal delirium also accelerates the cognitive decline in patients with dementia. So delirium can accelerate the cognitive decline, and patients may not reach their previous baseline. So it's really important to even closely monitor patients with pre-existing dementia because it really does change their clinical course and quality of life. Misconception 7. Delirium treatment should include psychotropic medication. As I mentioned earlier, that the knee-jerk reaction is to do something to manage the agitation. Most of the times, the agitation, as I said, I hate the term agitation because we don't know the semantics of it exactly. What do you mean by agitation? If the patient is just trying to get out of bed, we don't need to medicate for that unless, you'd rather have a social sitter to help. But I guess that's obviously, a lot of times we get calls to discontinue the sitter. But anyway, so, even though, we want in emergency situations or situations where, patient may be a danger to themselves or others or interfering with really essential medical care, pulling out at their tubes in the ICU and lines, we may have to use pharmacological interventions, but they are never first line. So in table 3, it gives a list of all the non-pharmacological interventions for delirium management. So one is obviously, asking exactly what the behaviors are and what are the target symptoms, because that would help you just use the least amount of medications. And the other thing is, like, if there are unnecessary lines, catheter, tubings, they should be discontinued. So no medication is approved by the FDA. APA guidelines, specifically mention that, non-emergency antipsychotic medication should be used only for treatment of agitation or psychosis in patients when symptoms are severe, dangerous, and or cause significant distress to the patient. The question is significant distress to the patient, not to the nursing staff, not to the CNAs. So as I said, we should use them for specific target behaviors and time limited. Once they are gone, one should try to stop them because ultimately they just end up with them post-discharge. Misconception 8. Patient is delirious due to a psychiatric cause. So of course, as psychiatrists, we are trained to distinguish delirium from a primary psychiatric illness. Altered acute onset, fluctuating course, altered level of arousal, it's not commonly seen in psychosis. Yes, with regards to disorganized thinking, it might become difficult. So in such cases, I think as psychiatrists, we can definitely help out in determining the patient's baseline, because we know what questions to ask. They talk about EEG changes, but it's not always ordered. And, the diffuse slowing, I think it can also occur in psychiatrically ill patients. So I don't think it might be, although they say it's not routinely ordered, but may be useful. So hence in delirium almost always has a physiological cause. So just because somebody has a psychiatric history doesn't mean that it's the behaviors or whatever we are seeing is because of that. Misconception 9, it is often best to let quiet patients rest. Of course, hypoactively delirious patients are the best patients for the floor staff because they don't bother anybody, they are withdrawn, they are not yelling, they're not getting out of bed. But however, these patients even require even more proactive involvement because if they're refusing food, not participating in therapy, then they are at risk of developing pressure ulcers, and they're not, participating in incentive spirometry. They can have more onset of pneumonia. And so these quiet patients should be assessed for hypoactive delirium. A lot of times hypoactive delirium is misdiagnosed as depression. So psychiatrists, I think, and on consult teams, I think we do try to explain the team about the differences, because 50% of the delirium is hyperactive. So hypoactive delirium is common and often under-recognized. So quiet patients, still one should evaluate them. Misconception 10, patients become delirious just from being in the ICU. So the historical misnomer, ICU psychosis, it's still commonly used. Another one that I've started seeing is on the medicine service is hospital-acquired delirium. And I don't know where that term came from, but somehow that's what the diagnosis is, number one. So you should never expect that simply you're in the ICU that you have to, you're supposed to be delirious. It's always due to some physiological insults, medical interventions, and then disruption in your circadian rhythm, because it's a high stimulus environment. You're getting vitals every hour, telemetry is going on, off, people are coming in to change you, to move you. And we are also using pharmacological sedation, which in itself can make their confusional state worse. And so again, modifying risk factors is important. And so, trying to see if we can maintain their sleep. They actually mentioned a study in which a meta-analysis which suggested that earplug use either alone or part of a multi-component approach with other sensory modification reduces delirium rate. In Society of Critical Care Medicine website, sccm.org, they have mentioned the ABCDEF bundle for critical care settings, where D is delirium. So delirium prevention, assessment, and management. So they do have a lot of information for ICU intensivists to manage delirium. So the conclusions, as we know, delirium is important. We as psychiatrists are very, very important in management, however, not always for the right purposes. I think depending on the volume of consults, I think in geriatric psychiatry, I do have the luxury of having lesser number of consults to see, because I only see the delirium ones. But I can actually spend time, but I can see on a busy consult service when residents and attendings are running here to see 20 patients a day, I think it becomes really hard. But I think we are the ones who can really play a huge role in kind of educating. And if it's possible for faculty in the hospital to give, interdepartmental grand rounds or case conferences, I think that would be helpful for like the young, our upcoming medical students and resident trainees. I've tried to present it a couple of times. I don't think if it has helped, but I'll keep trying. So, but yeah.
Okay, great. That was really good. You know what? I've heard every single one of those. I was like waiting for something maybe new, but yeah, every single, yeah, all of them.
So that's why I think that it's such a concise article that we should really distribute it. Whichever of us is working in academic settings, is to distribute to the chief residents.
That's a good idea, because I have a hard time, especially explaining one of the ones at the end, the ICU psychosis or ICU delirium, because that term is used by all the ICU attending. I mean, they use it
Yeah.
as if it's like still a thing. So it's they don't believe me when I say it's
No.
not really based on anything, you know.
Yeah,
So
I mean, I think it requires a huge cultural change, and I think that even though I do think Dr. Inui, I'm really curious to see that at the hospitals that she worked, whether they implemented the help program or not, because I think you can have a business model of implementing the hospital elder life program. You can hire volunteers to sit in with the patients, to have this formal like prevention program. But
mhm.
I'm just curious how the internists and other specialties are in other parts of the country. I mean, is it just, I guess, is it really, universal, or is it just some states? I don't know, but it really is amazing to see like that how delirium is just not considered
Mhm.
medical.
Yeah, and how it causes so many additional problems, and people don't really realize, oh, if we really address this delirium, the patient is going to improve in a lot of different ways,
I mean, it's going to
including
reduce,
saving the
yeah,
hospital money.
money and reducing the readmission rate. So,
Right.
but yeah.
Yeah. So yeah, I wouldn't say delirium is one of my favorite topics, but
I
it's
mean,
definitely, I mean, it's bread and butter, right? I feel
it
like
is, it is,
yeah.
it
So
is.
no, so that was a good review. Thank you. And if anybody has any questions, feel free to post them. As always, the CME is listed at the top of this post for how to get your free CME for watching the video. This Wednesday, I will be presenting the article, and it's on late life major depression and the use of exercise, which I'm really excited about. So I'll see you guys on Wednesday, and thank you again, Dr. Dhar and
Ramika, Ramika.
Ramika. Yeah, and everybody, will see you guys in a couple days. All right, have a good night.
Bye. Thank
Bye.
you.
Take care.